So how big is the impact of patient flow on hospital efficiency? Turns out it's pretty big. The smooth movement of patients through the healthcare system could revolutionise outcomes, reduce length of stay, and even alleviate pressures like ambulance ramping. Today, our hospitals grapple with a range of issues, from bed allocation challenges to inefficiencies in ward workflows. How can we ensure that patients are placed in the right beds at the right time? What role does real-time data play in reducing the chaos that often characterise hospital environments? And how do we design a system that frees up clinicians to focus more on patient care and less on administrative hurdles? Well, with me today is Nick White from Alcidion, and in this episode we talk about the tangible benefits observed from using electronic patient journey boards at Alfred Health, including a 12.1% reduction in patient length of stay, how consistent real-time access to patient information has led to a 67% reduction in call duration for bed allocation and improved overall efficiency, and the future possibilities of integrating artificial intelligence to further enhance discharge planning and bed availability matching. Collaboration starts with a conversation, Team HealthTech. Let's make it happen.
Welcome to Talking HealthTech, featuring content and community about technology and healthcare. We acknowledge the traditional owners of lands these conversations were recorded and pay respect to elders past and present.
Joining me on the show today is Nick White from Alcidion, no stranger to Talking HealthTech, and great to have you here, Nick. How are you?
Oh, good, mate. Good to be back.
Thanks
for having me on the show.
Back in the virtual studio, and we've done plenty of connecting out and about at in-person events and meetups and things, and seeing you've been busy with Alcidion and doing some work behind the scenes and have started to get some more comms out about a study that's been done and also some other things. So maybe setting the scene for those that might be unfamiliar, perhaps the cliff notes in terms of Alcidion, the space you're operating in, and what you do.
Yeah, so Alcidion, healthcare software provider, our focus is on supporting our customers to take advantage of the data that they've got within all of their existing health IT assets. We integrate with those existing assets, pull that data across into a fire events platform, map it all into a fire ontology, and then on top of that, we've got our applications. And that way, we're able to have real-time two-way integration with EMRs, PAS, RIS, all the various systems that the hospital's got in place, but we can present that through in a clinical decision support system, which is known as MyFlow, and we've got a number of other applications as well. To streamline patient flow, enable virtual care, command center capability, and various other capabilities that we've got that sit on top of our fire events platform. So that's a very quick Cliff Notes version of what we do.
Yeah, and people can jump back and check out quite a few episodes in the feed with Alcidion, which we'll link up up on the website. You'll be able to see under the notes from this one. So, but I'm keen to dive into some new findings that you've got, particularly around MyFlow, I believe, because it's one thing to have nice feedback, nice words to come from a solution provider that's created a solving a problem. It's even nicer to have feedback from customers. But I guess in this world of healthcare requiring evidence and insights and that kind of data to back things up, it's great to have some more concrete stuff. So talk me through some of the recent research around MyFlow.
Yeah, absolutely. And you're spot on, right? We have a lot of feedback from customers that tells us that we've released time for them and given them back time to care. But we wanted to go a little bit more pointed than that. And so we worked with the Digital Health CRC and Monash University to do a study of the recent deployment at Alfred Health and get some more detailed feedback and understanding of the benefits that were created through the course of a 12 to 18 month study. So that is the findings that I've got to present and talk through today, just to talk you through the kinds of things that we see in terms of the benefits areas and delve a little deeper into what that means for our healthcare system.
Yeah, look, and I've had a bit of a look over the different findings, and they all kind of are problems that you hear about within healthcare settings that clinicians, executives, everyone within the space are facing. So it'd be great. Let's go through them one by one, I guess, and we can kind of unpack that a bit more. But I can see here that the first one here is around efficiency in bed allocation. Talk to me a little bit more about that.
Yeah, so let me set the scene a little bit deeper as we get into the bed allocation, because I think it's important to understand how broad the implementation was. So Alfred Health, they implemented what we call electronic patient journey boards, or the Miya Flow dashboard that is you've seen before. We've had it on other podcasts, but they implemented that across 38 different wards across their 3 facilities. So it was a very broad implementation across the hospital system or the healthcare system. And the study, as I said, was done over about 12 months. And there are a number of areas that we found benefits. And one of the things that I'd say about those is they compound, they build on each other. And we'll get back into that. But the first one you called out there, the efficiency in bed allocation. This one's really important to me because one of the big problems we've got in Australia at the moment is that we're seeing ambulance ramping on a much more frequent basis. We're hearing about it in the news. The AMA's ambulance report card last year actually showed that every state had missed their targets in terms of transfer of care out of an ambulance into the ED department. So that represents to me that we've got blockages in the system. Now, a lot of people immediately react and say, well, our emergency departments are understaffed or we don't have enough beds in them. But in actual fact, it's a blockage right the way through the system. It's not just about getting people into ED. It's about getting people out of ED and into an inpatient bed, getting people from an inpatient bed down into the appropriate care service for them as they recover, step-down services, getting people onto virtual care programs, getting people into their home and caring from their home. Bed allocation is something that happens all the way through that process, finding someone a bed in the appropriate service for them. And the study found that call duration for bed allocation decreased by 67%. So what that meant was, if you what does that really mean in real terms, is that it's not taking as long for somebody to find a bed for a patient to go to because they're able to reduce that call duration. And so there's transparency clearly being provided in what beds are available and the capabilities of those beds. The process to allocate a bed is simpler. And overall, we're freeing up resources who were caught up in this process of phoning somebody, waiting to get somebody on the other end of the line, and then having a conversation about finding a bed, going through the process of finding a bed, allocating that bed, and then getting back to your work. So that process is much simpler. For customers who've got both our ED system and our electronic patient journey boards in the ward, that can actually be done digitally with no call. So you just make that request digitally. And in the Alfred, what we saw in the data was a 67% reduction in that call duration to find a bed. So massive impact in terms of that.
Yeah, that's material, and that flow-on effect would be significant, I imagine, too. We should probably come out in some more of these findings too. But what else? Like the second finding, talk to me a bit more about that.
Yeah, so the second finding is one of my areas of passion, which is around a reduction in outliers. So an outlier, just for people who are not familiar with what an outlier is in hospital terms, when we're talking about patient flow, an outlier is somebody who's in the wrong ward. They're being treated in the wrong ward. So say I'm an orthopedic patient and I come into the hospital system and there's no beds in the orthopedic ward and I end up in a different ward, right? I might end up in a general surgery ward or an oncology ward or wherever I end up. But the impact of that is that the care that I receive is obviously impacted in a way of some sort. Now, what we see from the data is that outliers tend to have twice the length of stay than a non-outlier. So it impacts your length of stay. The other data point that's out there is that an outlier patient has 40% higher risk of mortality. So they're just two indicators of the impact of being an outlier in the hospital. And the kinds of things that happen are the care team needs to come from the home ward to where you are. And so it impacts on the time that it takes to provide care to you as well. So there's a direct impact on our care workers around outliers as well. And there's much more that can be said around outliers. The study showed that there was a 17.7% reduction in outliers at the point of admission. So what that means is we're finding patients a bed in the target ward that we're trying to put them in more often than not. And so that reduction for me shows that we've managed to free up some capacity in the system, but also provide some transparency on what beds are available and being able to get those patients better matched. Now, in some cases, it's not going to have a great impact, right? So an orthopedic patient going into the wrong ward is probably a lower impact than, say, a stroke patient going into the wrong ward. And these are the kinds of outliers that we're trying to avoid, trying to minimize so that people are getting the best care possible that they can.
That makes sense. You don't want those high impact ones. That if there was a matter of time is of the essence, and if you're wasting that time going to the wrong locations, if you can avoid that seems like a no brainer. But I don't think it can be discounted either. The other ones, the seemingly mild annoyance of people being ushered from one place to another. But you see the impact. I felt it real time from a end punter point of view of in the hospital, where it's like if yes, it might be a mild inconvenience to me, but doing that at scale, that's impacted more than one person within the hospital setting. And to your point around compounding, these issues add up, right?
Yeah, absolutely. The biggest one for me is actually the impact on our care workers, right? Just the demands that we place on our care workers, not just for them to go outside of the ward where they are to treat a patient who's being cared for or in a bed in another ward, but it's also the demand that goes on those staff to resolve that outlier, to find them a bed and get them into the target ward that we're trying to get them into. And if we end up with multiple outliers that are going to multiple different home wards, you end up with a bit of a spaghetti system that we're asking our care teams, our nurses, to resolve. Much better if we can create capacity in the system and allow somebody to go into the target ward when they're admitted and not have to deal with resolving that outlier situation in the first place. So multiple different negative impacts of having outliers, and the more that we can do to resolve those or avoid them in the first place, the better.
Yeah, and there's much trickier things that we need our care workers to be focusing on, and we don't need that additional cognitive load. So that seems like a no-brainer. Hey, this next one interests me because we've talked a lot about obviously the operational patient flow side of things and making sure things are effective as possible. But a really important part of all of that is actually having the right patient information. So this is interesting to me, the access to real-time patient information. Tell me more about that.
Well, we got a whole podcast on that we did a little while ago, but in a very short snapshot of the summary of that podcast, the way Alcidion's Miya Precision platform works is that we plug into the existing health IT assets that the hospitals have got. We access the data, we pull it across into Miya Precision, map it into Miya Flow, and then present it on map it into Miya Precision and then present it on our Miya Flow dashboard. And we do that in real time, so that if something changes in the EMR, in real time, you'll see that change on the patient flow dashboards. If something changes in the PAS, same thing. And it's vice versa. If we change something in Miya Flow, we push it back into the source systems. So having that real-time data aggregated into a patient flow system is what's really making the difference here. When we did the baseline, or the team at Monash did the baseline data study, they found that there was about a 25% to 40% discrepancy between what was written on the whiteboards that were in the wards and what was in the EMR or the PAS system as a source system of data. So that's a fairly decent discrepancy. We also had a look at studies, and there are external studies that show that 59% of the time that there is a data discrepancy, a data issue, it impacts negatively on the patient experience. And that could be anything from a mild inconvenience to patient harm or even death. So wherever there is a discrepancy in data, we want to try and eliminate it. The study found that after the implementation of the electronic patient journey boards, we had 100% alignment of the data that was in the journey board to the PAS and the EMR system, to the source system. So we had 100% alignment between those data sources and eliminated all of that discrepancy that existed on the whiteboards. So this was a key finding for us in terms of just being able to show how effective Miya Precision is at accessing those source data systems and providing accurate, up-to-date information to the hands of the clinician when they need it.
Yeah. No, that's critical, isn't it? And I assume the only people that are unhappy with that are Officeworks with the reduction in sales of whiteboards and markers, but we can deal with that, and I'm sure that's bigger picture. It's super important. But that's great, and you see it too. It's such an area. All of these areas within that flow, that within a healthcare center, the post-it notes, the whiteboards, the little handwritten things to kind of plug those gaps that exist. There's ways to address that, and it's great to hear that there's that data that demonstrates that, and 100% is what we need. So
it's really interesting when you sort of reference the whiteboard and the joke about the whiteboards with Officeworks, and it's, I absolutely hear you, and it's a point. But when you read underneath the hood of that, right now we've got all of the beds on this digital interface, right? Yeah. TV screen, we can see all the beds up there. It looks the same as a whiteboard, much more comprehensive in terms of the data that's available, and it's updated in real time. But what you don't see is the fact that when we had a whiteboard, it was somebody's job to run around all of the wards and look at that whiteboard and write down, these are the beds that are available, and run back and then sit at the other end of a phone call. And when somebody comes up and says, oh, is there a bed available? They can go through their handwritten notes of what beds were available on the whiteboards that they saw. The problem is, the moment they walk out of that ward and somebody else goes and updates the whiteboard, their data is out of date. Yeah. So this real-time access to data, both ways, right? Not just for the clinicians to get access to all of the data that's available in the PAS and the EMR and the other systems we're integrating with, but also for all of the operational teams to have real-time access to what's happening on the floor, what's happening with the beds, what's happening with the patients.
Yeah, 100%. I'm looking at this next finding here in the study too, reductions in length of stay. That's also a really good thing.
So length of stay is obviously the holy grail of what everybody's, we're all trying to improve length of stay and support patients in getting home, right? That's the focus in a healthy way. Australia has had a focus on length of stay for many years. It's something that we're ahead of the rest of the world, right? And in the material that we've got that we present on this, we actually show Australia versus the UK. UK is about 8.3 days for length of stay on average for overnight stays. Australia sits at 5 days. And that's 2022 data. I don't have any data later than that yet that's been released. Interestingly, the Alfred already sat lower than that number. They sat at 3.15 in terms of length of stay and days. While we can't isolate it to the electronic patient journey board, what we can say is over the 18 months of the study, what we saw was a continued decline in the Alfred's length of stay down to 2.77 days. So a 12.1% decrease in length of stay on what was already an industry-leading length of stay. So we're proud to have contributed to that, but absolutely there'll be lots of things that the Alfred has done that has influenced that length of stay. And we're just really proud to be part of that story.
Yeah, I mean, it all plays a part, doesn't it? And I guess that's reassuring to any health system that, even in areas that may be performing well, there's always opportunity to improve in such important areas like length of stay. And yeah, you're right. It's a number of factors, but if one of those factors are failing it, then that's where it all kind of falls down. So it's great to contribute to that. And then on the other side of things too, the discharge planning, there's a finding in relation to that too.
Yeah, so I mean, these two findings are so hand in hand and related. So the discharge planning is an interesting one. It's all about thinking about when this patient's going to go home and how do we plan and support that patient to go home. What are the things that we need to do? And one of the key data points that we look for there is an estimated date of discharge. Is there an estimated date of discharge that has been put in this patient's record, and how can we then plan to that estimated date of discharge? In the baseline data, there was 61% of patients that had an estimated date of discharge in their record. So 39% of patients didn't have an EDD. Now, obviously, if we don't have an EDD, we're not planning for discharge. We're not thinking about when that patient's going to be discharged necessarily with a specific date in mind. So there were two things that changed. One was the EDD date became mandatory. And so 100% of patients now have an EDD in their record. And that's obviously a key one for planning purposes. The other thing that was done was if you change that EDD, you now need to record a reason code associated with why you're changing the EDD. And this is really important for supporting analysis in terms of why is the EDD being updated? Why is it being changed? What learnings can we take away from that? And how can we support our clinical teams to understand as early as possible and be able to predict as early as possible what they think the estimated date of discharge is? We're going to be able to go further than that as this data builds up, and we're actually going to be able to provide predicted date of discharges based on factors such as similar patients who have come in, all sorts of factors that go into the algorithm that will support that, but you'll be able to provide a predicted date of discharge and an accuracy on the estimated date of discharge about whether we think that that is really, accurate in terms of the patient being discharged. So there's all sorts of things that this allows us to do from a AI and predictive analytics point of view, having this data available to us. So this one's a really key finding for us, and we love the way that the Alfred implemented it in terms of supporting their clinicians around, just give us a reason code. It's okay to change an EDD if you need to. Just tell us why. And the fact that we now have 100% EDDs against the patient is just fantastic.
Yeah, no, it sounds like it's just the tip of the iceberg in terms of potential there. And you're right. And potential for innovative tech and AI to improve that even more. That's really cool.
The other thing it does when you go past that is we can also then say, well, hang on, if I predict that Pete is going home tomorrow, I can now start to say, well, Pete's bed will be available tomorrow. Right. So not only am I predicting your EDD and your length of stay and doing discharge planning for you leaving the hospital, but then also saying, right, the next patient, we can line that bed up knowing that we're expecting that bed to be available. Now, there's already work that's done around trying to say who do we think is going to go when, but it's that factor that we've gone from 61% of EDDs known to 100% of EDDs known, and now better information around predicted EDDs and therefore predicted bed availability. So this is all around how much capacity do we have, how much do we need, and matching that supply and demand.
Yeah. If it gets measured better, it gets managed better, right? And so that's that's super. Hey, this last one interested me because, we always talk in healthcare about the importance of focusing on workflow when building solutions for like technology solutions in healthcare settings. So it's like, well, understand the workflow and then, you'll be able to implement a solution. But in healthcare settings, in every different, like in a hospital, every different ward has their own way of doing it. Every clinician sometimes has a different way of doing it, depending on what day it is. So this findings around consistency in ways of working. Unpack that a little bit.
Yeah, it's really interesting. So the baseline study here identified that there were 30 different ways of working across those 38 wards that we were deployed into. So it absolutely highlights the point that you just made. And there's no doubt that those ways of working have evolved over time. What we were able to do with the implementation was reduce that down to 9 variations on a theme. And the theme is essentially the way that Miya Flow works is it's got a bunch of columns in it. And we've got about 200 columns that you can choose from and customize the way Miya Flow looks for you. And that's all configurable. The way the Alfred built it was they had 80% of those columns common across the different wards, and 20% of those were customized for particular clinical workflows. And so we've got 9 variations of the way Miya Flow looks, but in those 9 variations, 80% of it is exactly the same. But there are certain clinical workflows that require information that's not required. Give an example. If you were going into a maternity ward, it would have columns that were relevant specific for maternity. If you were going into other wards, they have specific columns that are relevant to the care being provided in those wards. So there's some customization that's being done on those 9 variations, but mostly you can go from ward to ward now, look up at the board, and you understand exactly what's going on. So what that creates is the ability for resources to flex, for you to be able to work in one ward today and work in another based on your capabilities and specializations. But it just creates that flexibility to be able to go from one place to the other and understand very quickly the information that's being presented to you. So this was a really great one. The Alfred's really proud of this, and the teams are really proud of how they've worked to come together around their clinical workflows and around where they've identified that there are nuances that need to be catered for, and the fact that the system had the flexibility to be able to cater for those different ways of working. Yeah, so it's a really great one. And I talk about this one in the context of the healthcare worker shortage that we have globally. I think the data point that I've read on this recently was that the WHO is forecasting that we will have a 10 million workforce shortage, 10 million person workforce shortage in healthcare by 2030 across the globe. It's just an astounding number. We know that there are specific numbers with regard to Australia in this space, and it is a real problem. So the more that we can do to support that flexibility in workforce, the better.
Yeah, right. Like that's it. If you've got workforce moving from one place to another, you want to be able to do things consistently. It's sometimes a challenge, I find, because at least from my own experience, there's elements of the clinician workflow that we have. It's almost like it's presented to you as it's a bit of an art, or there's a bit of a way that each clinician might do things, or each department, or we're a little bit special, we're a little bit different. And I can see, you raised some great examples there. It's like, it's just obviously that these different departments need different information, and that's what you need to cater for. But if everything's operating in its own little silo, then that's where it all kind of falls apart. And that visibility from a high level is required. It's not just from a high level. It's not just reporting up through to the powers that be. It's that if you're transitioning a patient, or if you're moving from clinic to another, or whatever it might be, you do need that consistency. As long as that workflow makes sense and it's not getting in the way and it's not kind of dictating how things are done, I think that then that's that kind of middle ground that we need.
Yeah, I think the point for us is always, how do we get our system as close to the clinical workflow as possible? So we built user interfaces that really try to get close to the clinical workflow. It's very easy to update systems, a couple of clicks, right? I read an article a little while ago now about an ED system that was deployed in the UK that was requiring 4,000 clicks a day. Just a crazy number of clicks. It was just a really poor user interface design. One of the things we focus on is that user interface design so that it's just intuitive, totally intuitive in terms of I can see the information regarding my patient, and there's a couple of clicks to do anything that I need to do.
Yeah.
And that's the way Miya Flow is designed. And it's really powerful in releasing time to care for clinicians, because they're able to interface really fast with what they need to do. But it's about trying to minimize that change impact, trying to minimize the training and the learning that a clinician needs to do to be able to interface with the system, and trying to reduce the amount of time they need to spend behind the computer screen, because ultimately our clinicians didn't get into the job that they're doing because they want to spend time behind a computer screen. They got in there because they want to care for patients, and we want to give them as much time as possible to care for patients. And so that's the way the UI is designed. And what we've been able to show with the work in the Alfred is that we're able to do that. We're able to create those various themes that really do mimic the clinical workflow, but provide the consistency so that it's easy to move from ward to ward as required across commonality between the ways.
Yeah, no, that's so true. That's so true. Look, I mean, these 6 findings in particular, they're kind of hitting the big ticket issues that we hear about within healthcare settings that need to be addressed. And there's definitely going to be, someone that's listening to this one that is keen to kind of dive into the detail a little bit more and consume some of that and absorb and kind of work out how that applies to them. Where can they find some more information about some of these findings?
Yeah, so the article itself, the study is a 40-page study that's available. So more than happy for people to reach out, and I can provide them with the study. But just to help people, we've created a more digestible 600-word blog on our website that goes through it. So we can throw a link to that blog into the webpage here and into the podcast, so that people can actually access that and take a read of themselves and see those findings. More than happy to share the study if there's people who want to get into the detail of the study as well. And talk through it. And happy to do a session around how this could apply within various health systems as well. One of the tools that I'm working on at the moment is a calculator. So if you wanted to take this study and apply it to your own healthcare system, put in your variables about how many beds you've got and so on and so forth, and output what the impact would be in your system. We're building a calculator at the moment that'll be able to do that and support people essentially doing a benefits model for their own business case about how they would move to a modern day patient flow system. Because there are a lot of people who implemented patient flow systems many years ago, and they're not taking advantage of the power of real-time integration, the user interfaces that we've got today, and the many other benefits of a system like Miya Precision and Miya Flow.
Yeah. Hey, that'll be really useful. Keen to see that, because if you can see that impact and see the numbers, then that really helps, rally the team internally to be able to make an impact. So yeah, we'll definitely be linking that up in the show notes of this episode. Thank you, Nick. And obviously Alcidion's got a strong presence on the Talking HealthTech website, and we've got the details for that here too. So always a pleasure to have a chat on the show, mate. Looking forward to doing it again soon. Thanks so much for taking us through the detail.
Fantastic. Thanks for having me.
We hope you enjoyed this episode of Talking HealthTech. Make sure you like and subscribe, and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.